Hello learners. So this is lecture 3 of module 1 and today we are going to talk about definitions and scope of reproductive and child health. At the end of this lecture, you would be able to define and scope RCH across the life course, explain service integration and the RMNCH plus A framework, and finally interpret trends and equity gaps in to inform planning. Today, I'll explain what reproductive child health actually covers and why it is more than a set of schemes. Think of reproductive child health as an organizing framework that connects services for women, newborn, children, and adolescents. It puts people's rights, dignity, and informed choice at the center. We will walk through these major components and the guiding principles that hold them together. By the end, you will see how the pieces fit into one continuum of care rather than isolated activities. To understand the scope, start with the problem of RCH is trying to solve. Services used to be fragmented, so families often fell through the cracks when they moved from one life stage to another. Rural and tribal areas face the biggest access barriers, especially in emergencies. Reproductive child health responds by integrating these services and strengthening frontline teams that links homes to facilities. This slide sets that context without going back into the detailed history you saw earlier. The key point is integration is the solution to fragmentation. Now, why RCH matters? Reproductive child health matters because the health of mothers and children predicts the health of the society. When we reduce preventable deaths and disability, we also improve learning, productivity, and quality of life. Healthy birth spacing and respectful maternity care protects both mother and the baby. Now, investments in RCH are therefore investments in human development, not just in clinics, and investment in the health of a nation. You will notice direct links to sustainable development goals, targets on health and gender equality. In short, RCH creates benefits that multiply across generations. In 1994, the ICPD reframed reproductive health as complete physical, mental, and social well being. That definition goes beyond treating diseases. It includes choice, consent, and safety. It also recognizes reproductive health as a human right that everyone is entitled to. The human rights lens changes how services are designed and how clients are treated. It is the foundation that India drew on when building RCH. Keep this broad, people centered meaning in mind as we discuss this topic further. India translated the ICPD vision into a practical architecture called reproductive child health. The idea was to bring maternal health, child health, family planning, and RTI STDs care under one coordinated umbrella. Local planning was encouraged so districts could adapt services to their needs. At the same time, the focus moved from numerical targets to quality and client satisfaction. This was a shift towards respectful, responsive healthcare. The scope we cover next reflects that shift in thinking. It also institutionalized a continuum of care from preconception and pregnancy throughout childbirth, the postpartum, newborn period, early childhood, and then back to adolescence, so no life stage is missed. District RCH plans, they linked resources to local epidemiology and platforms such as VHNDs, that is Village Health Nutrition Days, ASHAs, and referral transport to operationalize last mile delivery. Quality was hardwired through Lakshya labor room standards, standard treatment protocols, and mechanisms for client feedback to advance respectful maternity care. Monitoring moved from crude targets to outcome and experience indicators. Example, quality ANC elements, PNC, ENC within stockouts and referral timelines, enabling rapid data driven course correction. Three principles guide the spirit of RCH. First, client centered care. Services are organized around the person, not the program. Every person is given due importance, and the services are catered in a way that they fulfill the need of that individual person. Second, a rights based approach where privacy, dignity, and informed consent are non negotiable. They are respected and they are given value to. Third, equity. Priority is given to those who are hardest to reach. Accountability ties these principles together through monitoring and community participation. When these elements are present, families experience continuity and respect throughout their care journey, and they try to take in access, and this improves compatibility. Maternal health in RCH covers the full arc of pregnancy and the weeks after birth. Antenatal care screens for risks and prepares families for safe deliveries. It prepares the female for childbirth. It prepares the female to it prepares the female it prepares the female to take the first few steps of feeding her child. Skilled birth attendance and timely emergency obstetric care saves life when complications occur. Postnatal visits support recovery, breastfeeding, and recognition of danger signs. Good referral and transport connects homes, clinics, and higher level facilities at the right time. When these steps are linked, outcomes improve for both mother and the newborn, and that's our final aim. Child health combines preventive and curative services that work best together. Universal immunization protects against several diseases. Growth monitoring and counseling helps families respond early to undernutrition. Strategies like IMNCI standardize the treatment of pneumonia, diarrhea, and newborn infections at every level. Every childhood service also supports learning and development, not just survival. The scope is therefore broader than vaccines. It is about thriving in the first years of life. RCH treats family planning as informed choice rather than a target. Couples are offered a basket of methods and counseling to choose what fits their lives. Healthy spacing between births lowers risk for mothers and babies. Postpartum family planning makes services available when motivation is high. Bringing men into counseling shares responsibility and improves satisfaction. This approach respects everybody's autonomy while improving their health outcomes. RCH integrates prevention, testing, and treatment of reproductive tract infections and sexually transmitted diseases into primary care. This reduces stigma and makes help easier to access. Syndromic management helps providers act quickly even when labs are limited. Counseling and partner management reduces reinfection and transmission in the community. Linkages to HIV prevention and adolescent services ensure continuity. Addressing these conditions protects fertility, relationships, and overall well being of the family. Adolescents, a very important part of our community. Adolescents need safe space to learn and ask questions about health. Adolescent friendly clinics provide confidential counseling on nutrition, mental health, and sexuality. Life skills education builds decision making and respect for consent. Simple services like anemia control and menstrual hygiene support daily functioning. Delaying marriage and first pregnancy changes life trajectories for the better. Investing here pays dividends across life and into the next generation. Now, talking about RCH Phase 1. Phase 1 unified safe motherhood, child survival and care for reproductive tract infections, sexually transmitted diseases under one umbrella. The aim was to move away from fragmented projects towards integrated care. District level planning began to tailor responses to local needs. Communities were engaged to improve acceptance and coverage. While resources were stretched, the platform for integration was created. What matters for us today is how that platform shaped the current scope. A participatory planning approach was built through village health, sanitation, and nutrition committees. Panchayati Raj institutions, women's collectives, and accredited social health activists, participatory rural appraisal tools to map barriers and co prioritize actions. Sub-center microplans translated these priorities into due lists, fixed sessions on sites, logistics, and referral arrangements for each hamlet. Conversion with the integrated child development services and regular village health and nutrition days operationalized joint outreach and nutritional maternal child health counseling at the last mile. The health management information system and community feedback loops closed the cycle, informing course corrections and laying the groundwork for the reproductive, maternal, newborn, child, and adolescent health continuum, and later quality initiatives such as Lakshya, labor room quality improvements initiatives, etc. So, this was the phase 1 of RCH. What were the strengths of phase 1? Decentralization. That is bringing out the needs of the people from the community at the periphery. So, this decentralization allowed programs to reflect local priorities instead of one size fits all plans. Community mobilization brought services closer to the households and built trust. It gave ownership of the program to the community. Training and logistics improvements supported routine delivery of care. Client feedback helped identify gaps in respectful services. These strengths informed later quality initiatives. The lesson is that systems improve when communities and providers solve problems together. Now, phase 2 of RCH. It broadened the lens to include adolescents, tribal, and urban health while strengthening quality assurance. Emergency obstetric and newborn care networks were expanded and linked to referral systems. Monitoring frameworks created clear accountability for results. Convergence with the National Rural Health Mission increased resources and reach, of course. The overall direction was towards more inclusive and reliable services. This set the stage for the life course approach that followed. Several innovations changed behavior and outcomes in phase 2, like Janani Suraksha Yojana offered financial incentives that increased institutional deliveries among the poor. Large scale training standardized skill birth attendance across facilities. The poor females had to be given money incentive. They took them to the institutional delivery site. Ashas were given financial incentives for making the female go for institutional deliveries. So the graph of institutional deliveries significantly improved after this implementation of Janani Suraksha Yojana. Then IMNCI, that is IMNCI integrated newborn care with child illness management for better survival. Community platforms such as ASHAs and village committees improved outreach and problem solving. Together, these measures like financing, training, and community action, Janani Shishu Suraksha Yojana Karikram, then removed cost barriers through free drugs, Together, these measures linked financing, training, and community action. Janani Shishu Suraksha Karikram then removed cost barriers through free drugs, diagnostics, diet, and assured transport, including referral and dropback. Pradhan Mantri Surakshit Matritva Abhiyan institutionalized a fixed day specialist antenatal clinic for risk stratification and birth preparedness. Lakshya quality improvements in labor rooms and operation theatres, alongside expansion of special newborn care units, functional first referral units, and 108 102 transport, tightened intrapartum care and referral timelines. Home based newborn care and home based care for young child built systemic postnatal follow up. Danger sign detection and nutritional counseling using ASHA's dualists and community surveillance. The reproductive, maternal, newborn, child, and adolescent health approach unifies the entire life course from preconception and adolescent through pregnancy, childbirth, postpartum newborn care, early childhood, and then back to adolescent, so no stage is left behind. It operationalizes continuum of care by linking service packages across home, community, and facility levels with clear roles for accredited social health activists, that is our ASHAs, the ANMs, auxiliary nurse midwives, and medical officers and facility teams. Delivery platforms such as Village Health and Nutrition Day and Pradhan Mantri Surakshit Matritva Abhiyan provide fixed day, predictable access to counseling, screening, and risk stratification. Janini Shishu Suraksha Karikram entitlements include free drugs, diagnostics, diet, and assured transport, including drop back. They reduce financial and transport delays for mothers and newborns. A tiered referral network using 108 102 transport, first referral units, and newborn stabilization special newborn care units moves cases rapidly with bidirectional feedback to the referral point. Quality is driven through Lakshya labor room and OT quality improvement, standard treatment protocols, and maternal, perinatal death surveillance and response to learn from every adverse event. Home based newborn care and home based care for young child extend postnatal and early childhood follow up, danger sign detection, and nutrition counseling using dualists. Program management is data driven. HMIS, NFHS, blog dashboards, and gap analysis focus resources on high burden geographics and vulnerable groups. Equity is intentional. Micro planning for urban slums, tribal, and remote blocks ensures outreach, adolescent sessions, and follow up for left out and dropout families. In short, RMNCH plus A is the operational phase of RCH. Coordinated packages, reliable platforms, strong referrals and quality systems, and targeted equity actions that keep families on a clear pathway to better outcomes. Now, the flow of care, the continuum. Adolescence to reproductive age, to pregnancy, to newborn, then childhood, back to adolescent is a closed loop as is clearly visible in the picture on this slide. Gaps at one stage compound the next. For example, unmet need for contraception in adolescence, you have short inter-pregnancy interval, low birth weight baby, stunting, poor school outcomes. Now, preconception and adolescent services, that is, adolescent sexual and reproductive health counseling, anemia prevention and treatment, contraception, sexually transmitted infection care, and human papilloma virus in vaccination, reproductive health education feed directly into safer conception and healthy pregnancies. During pregnancy, timely, early registration for 4 to 8 antenatal care contacts, risk stratification through Pradhan Mantri Surakshit Matritva Abhiyan, maternal nutrition with iron folic acid or multiple micronutrient supplementation, blood pressure and urine testing, tetanus, diphtheria immunization, the birth preparedness setup, a safe interpartum period. In labor and delivery, quality enter Lakshya framework, skilled birth attendance, partograph use, active management of third stage of labor, and newborn resuscitation prevents the major catastrophic failures. Postpartum and newborn continuity relies on Janani Shishu Suraksha Karikram. Entitlements, which are free drugs, diagnostics, diet, as we earlier discussed, including postnatal care within 48 hours and on day 7. Home based newborn care visits, early initiation of breastfeeding, and KMC kangaroo mother care wherever indicated. Childhood care continues with full immunization, growth monitoring, infant and young child feeding counseling, deworming, vitamin A supplementation, integrated management of neonatal and childhood illnesses, and home based care for the young child to support neurodevelopment and catch up growth. Counseling, referral, and follow up are operationalized through due lists, village health and nutrition days, then emergency transport services, and bi-directional referral notes so families do not drop out of care. Teams coordinate across levels. Ashas, ANMs, medical officers, staff nurses, first referral units, newborn stabilization units, and special newborn care units with clear escalation criteria and feedback to the referring point. Equity microplans for urban slums, tribes, and remote hamlets and adolescent clubs target left out and dropout groups, while village health sanitation and nutrition committee reviews and community scorecards keep services accountable. Finally, Health Management Information System and National Family Health Survey dashboards, along with maternal death surveillance and response and perinatal death surveillance and response, close the loop by using data to plug stage specific leaks and prioritize high burden geographies. Community ownership turns programs into services that people actually use and want to use. Ashas link households to the system and build trust through regular contact. Anganwadi centers support nutrition and early learning for young children. Village health committees, they plan locally and hold services accountable. These platforms help identify barriers and tailor solutions. When communities participate, uptake improves and improvement lasts longer As the communities and the people take ownership of the program, community scorecards, social audits, and public display of due lists create transparent accountability and prompt course correction. Self help groups, Mahila Arogya Samitis, and adolescent peer educators extend health messaging, track defaulters, and mobilize beneficiaries for VHNDs. Untied funds at sub centers and VHSNCs enable quick, locally decided fixes like transport for high risk ANC or repair of hand pump. Grievance channels and digital tools, wherever available, capture feedback and service gaps, ensuring that local voices directly shape microplans and referral arrangements. Over time, sustained investments in RCH has lowered maternal and infant deaths and reduced the fertility. As you can see in the two graphs in the slide, the first one is about infant mortality rate, and there is a significant decrease in infant mortality rate from 2017 to 2023. Likewise, in the second graph, which shows total fertility rate has also decreased to a large extent from 2017 to 2023. Now, these changes are there both in rural and urban areas. More women deliver in facilities with skilled attendants now. Immunization and early antenatal registration continue to expand through some districts lag in that. The big challenge now is closing the gaps between regions, income groups, and rural urban areas. Quality and respectful care need constant attention as coverage grows. The direction is positive, but equity remains the core test of success. To conclude, RCH reoriented the system from population control to rights and dignity. Its scope spans the full life course with clear links between stages and platforms. Community participation and accountability are essential to sustain gains. The next frontier is equity and respectful experience for every client. If those pieces stay in focus, RCH will continue to deliver health and social benefits. Thank you for engaging with the scope and purpose of RCH today.